Hey, my name is Thomson Kuhn. I'm with the American College of Physicians part-time at this point. And I'll be moderating this session. I was really excited to see this session come together. We're really trying to broaden everyone's perspective on the entire quality management ecosystem. We all have a role to play, and we are somewhat familiar with all the other moving parts, but it's really complex, and there are a lot of people that are doing wildly different things in the quality space, and I hope we're all going to improve our understanding of the depth and breadth of what's happening in quality improvement, and having the perspective of other players, I think, will help as we try to improve the system and fix the problems. So I'm going to, let's see. Okay, excellent. Well, that's me. Okay, John DeMore, first up, is a published researcher and speaker in the field of health IT, dealing with clinical and operational performance improvement for providers, exchanges, and payers. His research has been cited in federal regulations on health IT, meaningful use in particular, and he serves as an advisor and contributor to both NCQA and HL7, has 15 years experience working with medical interoperability and quality measurement. He's founder of Diameter Health, which informs actionable clinical insights through the normalization, cleansing, deduplication, and enrichment of medical data from across the care continuum. Next up is Sue Feldman, Director of Graduate Programs in Health Informatics and Interim Director of Graduate Programs in Health Quality and Safety at the School of Health Professions at the University of Alabama, Birmingham. Dr. Feldman has dual associate professor appointments in the School of Health Professions and in the School of Medicine, and her research focuses on health IT systems. She also serves on the Health Informatics Accreditation Council and has studied and developed graduate-level health informatics curriculum. As a registered nurse for over 30 years, she brings a unique clinical and informatics blend to everything she does, grounding policy and theoretical with practical. She's published in a variety of top-tier journals and conference proceedings, served as a program chair for several national forums, has a master's in education and a PhD in education and information systems and technology from Claremont Graduate University. Next up is Ryan Howells, principal at Leavitt Partners. He works with clients focusing on competencies required for risk-bearing entities transitioning to the value-based economy and how the implementation of technology can improve the triple aim. He has over 20 years experience in healthcare, currently executive director of the Private Exchange Coalition, the Medical Technology Alliance, and helps lead CARIN, a multi-sector public-private alliance focused on providing consumers digital access to their health information. He received his MHA from USC and has a BA from BYU, and is a project management professional. David Kendrick, MD FACP. Are you a member? Mm-hmm. Okay, good. Just checking.
Paid my dues.
Okay, excellent.
That's what he was really asking.
David is the principal investigator and CEO for MyHealth Access Network. If you haven't heard of it, it's pretty incredible. It's Oklahoma's nonprofit health information network, ensures that every Oklahoman complete health record is securely available where, when, and where needed for care and for health decision making. MyHealth served more than 3 million patients and is focused on improving health in Oklahoma and beyond by implementing a community-wide infrastructure for health IT. MyHealth was one of ONC's beacon communities and continues to serve as a convener and data aggregator for Oklahoma Comprehensive Primary Care Initiative, which has shown significant quality improvement each year and more than $100 million in savings. MyHealth is focused on providing advanced health information technology exchange, community-wide care coordination tools, and a robust decision support platform to support providers and patients in improving health. He's a member of a number of boards, including the National Committee on Quality Assurance, I don't know who they are, Strategic Health Information Exchange Collaborative, SHEIC, Network for Regional Health Information Improvement, Advisory Board to the Sequoia Project, and convening faculty to the Comprehensive Primary Care Program, CPC. Serves as senior counsel on interoperability for the ONC. And James Kirkwood, Director of the Division of Healthcare Innovation at New York State Department of Health, Office of Quality and Patient Safety, where he oversees the State Health Information Network for New York and the State Information Model Grant. Prior to this, he was the Vaccine Program Manager overseeing Vaccine for Children program. He was previously the Senior Director for eHealth at the Association of State and Territorial Health Officials, which included a detail to the Office of National Coordinator for Health IT and Centers for Disease Control. Okay, what we're going to try to do is give you a sense of some of the different steps in the process of dealing with quality measurement, quality improvement, and the various stakeholder groups involved. I'm just providing this as kind of a reference point as we go through the discussion. I'm going to start and run through a series of questions which each of the panel members will answer. I'm going to start with John Demore, and I will ask, first of all, if you want to start. He has a couple of slides that he would like to start with, but basically the first question is going to be, what is your role in the quality management and quality implementation and quality improvement space?
Okay. Great. Thanks so much for it, and there we go. My role, simply is I'm a data guy, and that's really where I find my life. I don't write quality measures, even though I try to help out on a national basis for it. My day-to-day is really spending with millions of patients, hundreds of millions, if not billions of clinical data elements, and being able to do things like quality measurement, like population health on a routine basis for it. And throughout today, and certainly in the national dialogue, what we've all heard is that we want to transition to a value-based payment system, one where the quality of care actually influences how much payers will reward practices, physicians, hospitals for their actual care that's delivered for that. And one of the key messages I want to get across in a couple slides is that where you do quality measurement actually matters. It goes back to a little bit what Shahid said at lunch for it, which is there's a lot of institution-based quality measurement being done right now, which is you have these different programs set up for these different ecosystems to be able to do quality measurement for it. However, there's only one actual quality measure, which is the actual outcome of the patient. And when we think about that in context of where you do quality measurement, it matters a lot. So historically, in the most simple way of being able to do quality measurement would be that we know we want to have payers funnel that money to the providers in the hospitals for the care that they deliver for that. And maybe we could just have the providers calculate the quality at the locus of care, at the location of care for it, to be able to give feedback to the payers so that they could use that as an adjustment mechanism in their value-based purchasing for that. That actually has a lot of historic precedence. It's been done for a long period of time for it. And that's actually the one that was really espoused as part of the Meaningful Use program, which was doing these calculations as a byproduct of the EHR. You would be putting all these data in, and as a natural byproduct, you get out a quality measure, and you'd be able to do quality improvement based upon that. However, there's alternatives. In addition to being able to calculate that quality measure locally, you could also share that data with a health information exchange, with a registry, and that registry might be a medical society for it. You often share clinic or billing data with clearinghouses as well for that, and historically, that's obviously where a lot of the data for HEDIS comes from for that. Quality measurement can also be done there. And you could actually share that data back to the individual providers and be able to have a synergistic quality improvement program that's done by an independent body for it. And there are some advantages and disadvantages to speak to on that for it. But we also have another locus where quality can be done, which is at the payer for it. So when you think about the conventional HEDIS measures, the billing data flows from the providers through clearinghouses to the payers for it, and the payers will actually calculate quality for it. But we also have CMS doing that for some of their programs. So you think about the IQR and patient quality reporting and the 30-day readmission outcomes. That's actually calculated by CMS. CMS determines what is your risk-adjusted readmission rate, not locally being done at the institution for that. All of these different locuses have different impacts in terms of how you measure quality for it. And where you measure quality matters, but at the end of the day, there is only one thing that matters, which I think is what Shahid was speaking to, which is the patient outcome for a lot of that. So I apologize, the icons didn't come up here for a lot of this. But one of the advantages of doing things at hospitals and clinics, which is something that we've done historically, is that when you had episodic measures, and something where it was a process measure where it was just about that visit or that hospitalization, it made a lot of sense to do it locally for that. And having all the data in one system really eased the calculation burden for that. But one of the challenge for that as we move to outcome measures, as we move to longitudinal measures, is that no one provider has all the data that they need to be able to calculate the quality outcome for that. So you don't know whether that 30-day readmission has occurred at that one site, if it occurred at another hospital for it. Or for a more ambulatory measure, you don't know the most recent HbA1c if that data hasn't been pushed back to you in your EHR for that. Doing it at the exchange has the advantage of being able to collect longitudinal information across the care continuum for that. But it has a burden of being able to normalize the clinical data for it. And it's also a relatively new program that's being done through QCDRs to do quality measurement at an exchange or a registry level for that, and not one that was really the focus of meaningful use for it. Finally, you have payers. One of the advantages is that they have the strongest longitudinal claims data available on the patient for it, but the challenge there is multi-source data normalization and the latency that's associated with that information to flow from point A to point B for it. So that was really what I wanted to do to just kick it off in terms of my role as a data guy for it, and one of the key messages I want to deliver today is that where you measure quality matters a lot.
Good. I think that'll help the other panelists. Sue?
So my role is actually a lot more straightforward. What we do is educate leaders to impact clinical quality outcomes. So we have a master's degree and a certificate program, graduate certificate degree. And what we do is we educate people to work in organizations like all of yours. And the idea is that they have an appreciation for what goes on in the clinical environment. So it's not just data for data's sake. It's not just pulling the data to answer a measure or answer a question or report it, but rather it's understanding what goes behind the measure, what makes up the measure, what feeds into the measure, and then also the clinical outcomes that come from all of the process measures. We also, feeding into that, we teach students to use health informatics, and we also have simulations in healthcare that can help clinical quality outcomes.
Thank you, Sue. Ryan?
So my role is one of being a convener. We at Leavitt Partners was started by former Secretary Mike Leavitt when he left public office about 9 years ago as Secretary of Health and Human Services. And while he was in public office, he had a reputation for bringing together both public and private sector partners in a multi-sector way to solve really difficult problems within healthcare. We've extended that model now into the private sector, and right now we run about 25 to 30 different alliances on specific individual problems in healthcare with actionable results. And so reason had an opportunity to connect today is the opportunity to talk to you about what we're doing in what's called the Carin Alliance, CARIN alliance.com. And the alliance itself is formed around the ability to advance consumer-mediated or consumer-directed exchange. Given we've got a number of fire folks, and I heard some not necessarily advocates of fire per se, I won't comment on the good or bad about fire, but the idea here is that we are moving into a world of APIs. And so because we're moving into the world of APIs, finally, we can extract the data out of the system in meaningful ways. And along with relying on groups like HIEs to my left here, which is wonderful to have that ability to do that, and they've done a ton of heavy lifting over the last few years, we now have a distributed way in actually accessing that data via the APIs. So for those who do not know, with the QPP measures and specifically around MIPS, as of if the final rule stays as the proposed rule did, as of January 1st, 2019, every single provider in the country who is participating in the MIPS program needs to actually be compliant with implementing the APIs that are being shipped from their EMR vendors as we speak. And as a result of that, by our estimates, Leavitt Partners estimates, more than 500,000 physicians around the country are going to be implementing these APIs. And as a result of them being compliant with MIPS, they now have an opportunity to then be able to access EMR information on behalf of consumers using a third-party app of their choice. Now, why is that important? Well, it's important because A, it's going to be mandated, but B, I think it's even more important is that it is data exchange outside of HIPAA. So the other reason I'm up here is to break paradigms a little bit, and I'm glad Shahid did that a little bit earlier, which was wonderful. The paradigm we've been living in, all of us have for a long time, is HIPAA-related data exchange. Covered entity to covered entity, we understand it, we get it, and it scared us to death, right? So we were just very, very nervous about all of this stuff. The data exchange we're talking about is covered entity to non-covered entity. That is a completely new paradigm. It's something we've never done before at scale in healthcare, and it is something that scares the daylights out of providers around the country. The Caring Alliance was brought together to try to develop a trust framework for how we do that. How do we agree upon how that data should be exchanged outside of HIPAA? We have some of the largest providers in the country around the table with us, payers, pharma, consumer platform companies, health IT companies, every major EHR in the country, either through their association or directly, consumer advocates and consumers themselves. It's a very robust group of more than 40 organizations and over 150 people that is, and working with the ONC and OCR and FTC and others that are saying, look, there needs to be a way in which we can move this forward significantly. I'm also glad that Shahid mentioned earlier on Seema's comments on Monday. That's a big deal. And it's a big deal because, number one, they're going to scale back the number of quality measurements going forward. But number two, I think it's even a bigger deal that she is talking about consumer-directed healthcare exchange or consumer-mediated health information exchange. What we believe you're going to see over the next few months, and you can mark my words on this one, is the idea that we're going to get out of the mindset of the provider-specific mindset, the institutional mindset, and we're definitely going to move into the consumer mindset. It is a bipartisan issue. It is something that is a somewhat of a quick win, at least in terms of healthcare. Because the Republicans have failed twice, they're looking for victories on this stuff. I can tell you there is an opportunity here that is significant. I think from this group's perspective and this room's perspective, then it becomes, I think, very much how what Shahid mentioned is from a quality measure standpoint, what does that actually mean? So I'll end with this. What we are doing tactically is we're developing a trust framework for how to exchange data outside of HIPAA. That's a big deal, and we're working again with ONC and FTC to make that happen. But number two is we're trying to find practical ways to do that outside of the provider portal. So as you know, today, in order to access your data, you've got to go through, I should say the patient portal rather than the provider portal. You have to go through the patient portal for everything. We're trying to figure out ways to do that remotely and outside of the patient portal so that we still get ID proofing, we still get authentication, and we can still do patient matching. The difference would be that the consumer is directing that entire approach. We can do it in other industries. We're hopefully going to be able to do that now in healthcare.
Thank you, Ryan. David.
Well, thanks, guys, for the teeing up the sort of the background on this piece of information, because I have a 75-slide deck required to do that. So yours was much better and more brief. You guys will get the 75-slide deck tomorrow. But so I did engineering before medicine, and I spend most of my day thinking with my engineering brain mostly and my medical brain secondarily. And I originally I did public health and informatics beyond my clinical training because I wanted to work at the systems level, apply engineering across the system. And I kept running into the same problem. I went to work for a pretty innovative company that was doing a lot by leveraging higher math on clinical data to actually predict not just what the rate of heart attacks or strokes might be in a community based on a certain number of interventions, but which people in that community were going to have the heart attacks and strokes, which to me as a clinician was sort of the holy grail. We've got to know who to intervene on to do anything about it. To harken back to the great talk we just heard, it's got to be actionable information. Unfortunately, what I ran headlong into in that environment was the substrate didn't exist. We did not have the data that was person-centric, not institution-centric, but person-centric, that could be used for that kind of work. And I always, coming again from the engineering side of my brain, if you can't model it with numbers, if you can't put it in a spreadsheet and put some numbers to it, it's probably not real from an effect perspective, or you've got to get down to the point where you can put numbers to something. And we just couldn't put numbers that worked out. And what we discovered were that when two folks are in clinic together and the patients see the same two people in the clinic, that they're now sharing the effect size of the performance that they're having across the patients they happen to both share in common. And so teasing out one person's performance from another is already mucked up in that scenario. And so when I made the decision to return back home to Oklahoma, it was to try and figure out if there was a manageable size problem, a manageable size place to tackle this problem. And so I began immediately after becoming a believer that the missing substrate was going to be the issue in pulling together health information exchange. It was not just, by the way, clinical data, but we're working with lots of other kinds of data now as well, and trying to paint the whole person picture of information. And so now we've aggregated some data. Now we're about 3.5 million patients, as much of their stories we can get, but we think we're only about 45 to 50% of the action in Oklahoma in terms of healthcare data, and maybe even a little less than that. But already what we see is that more than half of the people in Oklahoma, all comers, healthy and sick, have data in at least 2 EHR systems. That means every time I see somebody, there's a coin toss chance that I'm missing a piece of information that I needed to make the right decision. And certainly when I'm measuring quality on half the people in my data set, I'm missing information that's relevant for quality. Now, you give the population one chronic disease like diabetes, it jumps quickly into the 85% range. And then if you look at people who have been to a health system, meaning they've actually experienced care somewhere, it jumps to like 93 or 94%. So essentially, what we've been doing is sort of looking at the institution and maybe even the individual doctor within the institution, and we've set up ourselves to measure how that provider is doing based on the people they've seen that day or that year, that period of time. And the challenge that we have seen with that is that you get a completely different answer if you look at the whole experience of care from a patient level and note that they've been referred to an endocrinologist who got that A1C under control, and yet for that same person you're going to have two different values reported in the measurement, the one that was out of control in the primary care office, the one that was in control in the endocrinologist's office. What we really care about is what's the health of this population, right? So we break everything down to individual people and calculate their quality measure, their performance on any given measure, and then we build those back up to individual doctors who took care of them, to institutions that they were seen in, to whatever the slicer you want, the medications they were on or any other element, to determine what the performance is. And so by doing that, we've been able to get a sort of a unique perspective on measurement, but it's a perspective that meets many other institutions' needs, like commercial payers, like the employer who just wants to know how their employees are doing. And by the way, it sort of obviates a problem that we've run headlong into, I think, and it's going to become much more prominent with the publication of performance through MIPS, which is if I'm in an academic practice, as I am, and 90+% of my patients are dually eligible, Medicare, Medicaid patients, highly complex, and I have 5 commercially insured patients, my blood pressure control score is not going to be nearly as good as somebody who's entirely young, healthy, commercially insured patients. And now I've got a tremendous incentive to change my payer mix and to change the patients I see and to fire the sick ones. And I'm very worried that we're setting ourselves on a course as a nation when there's a very public dashboard printed that shows my performance, and I'm going to look not as good as somebody who I know I'm at least as good a doctor as, based solely on the fact that I've accepted more complex or sicker patients. And that's a classic answer you get from doctors, but in this case, the methodology would say that there is an issue there. So just to wrap it up, I think that the next level of this, if we do go with patient-centric measurement, is to start to think about how we start to cross political boundaries and other boundaries, maybe EHR systems and other boundaries, to make sure that the whole record is intact for the patient. So we've been working on a model with the other health information exchanges around the country to connect, called the Patient-Centered Data Home, to gather the HIEs that are participating, not yet all connected, but that are participating and could connect, cover about 210 million lives. So that's a good chunk of the country.
Excellent. Thank you, David. Jim.
So I'm at the State Department of Health in New York and Albany, which is where the state capital is. We have a few roles when it comes to measurement and when it comes to interoperability. So we're we're a payer, Medicaid. So I think Medicaid in our state is $68 billion a year, which is a large number, as you can imagine. We're also the regulator, so we're probably a little more active in the regulatory role when it comes to health information exchanges around the country, where we have health information exchanges that are certified to be qualified entities, is what we call them, not to be confused with the Medicare qualified entities. And we also require our regulated facilities to connect and make their data available to those entities. And that's important for us because the goal of the department is to ensure that data is available, and we're working more and more toward high quality and standardized across the care continuum, so we can do things like, start out as query-based exchange, but focusing more and more on quality measurement and population health measurement, which is our sort of population health measurement being our other roles, a very large agency. So we have Medicaid, regulatory, and we also have public health within our agency. So working across it, we're doing a lot of work on, again, supporting our value-based payment work. Our Office of Health Insurance Programs, which oversees Medicaid, has developed a Medicaid value-based payment roadmap, where they're looking, like CMS, to try and get 80 to 90% of care into a value-based payment contract and structure, which is going to, by, I think, 2020-ish, 2019, 2020, which is going to be a big lift. So I think from our perspective, and the other side of me that deals with our SIM grant, where we're supporting providers, primary care practices to get ready for those value-based payment contracts, and how can they sort of interact and take on some of that risk, because it's going to be a very different world where a provider is becoming essentially a risk-bearing entity, and so the numbers that they have to be able to see, so one patient doesn't blow them out of the water with this, with some of our small number problems, is going to be pretty huge. So some of the other work we're doing is on encouraging them to get to what we're calling our advanced primary care model, and inclusive of that is also connecting to our health information exchanges, and then eventually the goal is to really. What we're supporting is really focusing on data quality within our health information exchanges, and also supporting so that data can be used for quality measurement over time. Focusing on labs first and then expanding on to other measures.
Excellent. Thank you. Okay, next question. What's the big problem you're working on right now?
I would say that the two big problems that we're working on, it's hard for me to pick just one for it, is data quality. For working with a tremendous number of different EHRs, different providers, different settings for that. And one of the biggest things in data quality is data completeness, which is just are all the data there that you need to have to be able to appropriately calculate a quality measure, and do it automatically, like was said earlier today for it, which is getting rid of a manual process of trying to backfill in the holes for that. And the second thing is trying to connect all the pieces, which is part of what we're talking about today, of being able to give that feedback loop so that you can have a continuous quality improvement for it. We need to move out of a modality where it's just quality reporting for a regulatory purpose or just for a payment purpose if it's just a small number, to one where it's quality improvement because this is the right thing for the patient.
Excellent. Sue.
So I would say many of the things that we're working on are the same that you're working on, but from a little bit different perspective, in that we are educating people to be able to do those things. And so data integrity is a big issue. I think that's no surprise to anyone. One thing that I was thinking about earlier, and in terms of how we are educating students to go out there into the world and think of clinical quality reporting as a subset of overall clinical quality improvement, is something that Dr. Jaffe said earlier today, and he said quality seems like an afterthought. And so I started thinking about that, and I started thinking about how are we educating our students to actually apply the knowledge that they're getting in their graduate programs. And one of the things that I started to think about was that Health IT can actually help make, instead of having quality be an afterthought, Health IT can actually put it in the forethought. And eventually, and I think through some of the things that my co-presenters have said here, I could see Health IT being the mechanism that makes quality reporting or quality documentation not even a thought, where it just happens because it's just one seamless process or many seamless processes that all kind of weave their way into one. And so I would say that's the major focus that we're working on.
I like that. Make it unseen.
Absolutely.
Yeah. Ryan?
I think it's really, we're being very tactical in the alliance that we've started, is that the ability for the providers to actually turn on their APIs. Epic has shipped 90%, Epic has shipped their upgrade, the 2015 certified upgrade, to 90% of their customers, but only 50 of them have actually turned it on. So one of the things we're struggling with is that you've got chief privacy officers saying, I don't know if this is a good app or a bad app or not, or what's going on, and do I need to have legal approve it, and how do I figure this out? So what we've been trying to do with at least the alliance members that we have is explain, and luckily we have OCR around the table to help us do that. Devin's not at OCR anymore, but when she was there, it was great to have her around the table, which is this idea that they say, you know, actually, covered entity to covered entity exchange, you need BAAs and you need the HIPAA privacy and security ideas in place. But with covered entity to non-covered entity exchange, there is no BAA that needs to be there. So if you're an app company or if you're an organization that's a non-covered entity and you're having a covered entity tell you to sign a BAA, you tell them, stop it. Please stop the craziness. It is not necessary. In fact, it is not required by law in any sense of the word. And in addition to that, I can quote her now that she left, but she said this so many times to me and to others in the room, is that if a non-covered entity like an app is going to access information from an EMR, the CCDA information, that is mandated under law. Under HIPAA, when an individual invokes their individual right of access and provides consent to the covered entity, that covered entity is mandated to provide that information. So that, again, changes everything. So we don't have to have a whole set of BAAs in place to make this happen. We can actually have consumers request their data. Ultimately, our long-term goal is to have any consumer use any app to download any data from any provider in the country. We think we're going to get there, and we're making progress along the way. In fact, we think we're probably about 2 years away from that happening. Now that's obviously revolutionary talk and somewhat pie-in-the-sky type stuff, but we're very close. There's a few things that we need to overcome, but most importantly, it's the business and policy aspect of this to making sure this happens. MIPS is going to help because they have to do it under MIPS. That's going to really help us significantly. But we also need to increase demand. All of the EHR vendors have gone under because they haven't been able to access, not EHR, I'm sorry, PHR vendors, the personal health record. Microsoft Health Vaults and all those guys have given up because they never could get access to the data, right? So they had a great idea 10 years ago, 15 years ago, it's now gone. There's only a few that are left, but there are 250,000 consumer-directed health IT apps in the Apple iStore, the App Store itself. We need those 250,000 apps to start requesting EHR data on behalf of patients. If we could do that, EHR vendors will step up and they'll say, yeah, this is really a great idea, because they're all on board with this, just so you know, at least the major ones are. They want to give access, electronic access to consumers via the apps. They've told us that many, many times, and they're doing things in order to make that happen. That's a really good sign. We're moving forward. From the standpoint of quality, how that changes it certainly is it enables that data to start to flow through the system in ways that are a little bit different than what we've had previously in doing from covered entity to covered entity exchange, but it allows the consumer to then be at the forefront of their information, which is really powerful. At least we think so.
Excellent. David?
So I've been on record as calling out one of the major problems we face or challenges we face is being able to get the data liquid. You just heard about personal health records going under because they couldn't get the data, couldn't move it where they needed to. And I don't actually think we have as much of a data liquidity or data quality problem as we do an incentive alignment problem. And I think that we need to look pretty carefully at our policies around these incentives and figure out how to make sure that they're aligned with the one true north, from my perspective, which is that every patient has their complete longitudinal health record available wherever and whenever they need it for decisions about their care, which would include this model, as I understand it, which would include having a person-centric record and a health information exchange to be where they need it. But it would also include all my records being available in a commercial EHR product if that's where my PCP needs them to be able to make decisions. Unfortunately, though, there are a number of issues that get in the way. First one is money, and the biggest one, and it is the fact that there are. We heard a few months ago about eClinicalWorks and a massive fine for claiming to have functionality they didn't actually have. We flagged that a similar issue even before that one. There are other vendor-specific issues out there that get in the way of making this data liquid, and it has to do with the fact that it's often an afterthought or a smaller part of the organization that's focused on the interoperability component of these products. We have yet to see a perfect CCDA file or a file of a CCDA type that could be used to calculate all measures. I know the QRDAs were intended for that, but as an engineer, it's not very efficient for me to have one file per patient, per measure, per version of the measure to do something with it, moving a lot of data to get very little value, whereas the CCDA has everything, or could have everything I need, and plus I could use it to take care of somebody at the point of care, right? So we're advocating for thinking about making either the CCDA more robust or having some components of it that have the measure-specific dates and times, which is mainly what it is. It's missing. And also for making sure that the incentives do align. I've previously testified publicly about the fact that we find they're hard to get your hands on, but some vendor contracts have language that are gag clauses that prevent providers from talking about what's in their contracts. In the competitive space, that's a fairly common thing. Unfortunately, it does hide some things like the identified version of all the data in my electronic health record product gets to go to the EHR vendor, who then gets to turn around and monetize that data, which now creates an incentive for that EHR vendor to not want that data to go anywhere else because it's a product they can sell, right? The addition of population-based, the emphasis on population-based health is an upsell opportunity for every vendor to their already captured client population. And so that creates an incentive to not work with, push data to other innovative opportunities. I think the APIs are a part of the answer there to be able to get that data to move. But, speaking about myself as a patient, I'm not always motivated to track down information and assemble it for my own health, even though I know it's the right thing. And I want someone to be an advocate on my behalf often. So if we can get the consent process to be able to impanel a team for me on my behalf to be able to pull that data, then I think we're really cooking with gas. So I think the issue is really about incentive alignment and thinking carefully about how those incentives get aligned and to ensure that one true north is met. Granted, that's probably a process measure, but if we could report on it, then we would have the substrate I was talking about earlier to do all the great things we need to do in quality measurement and health improvement.
30 seconds to answer David's question really quickly. The cool thing about it is that once the consumer requests access to their data, they can then delegate that data to anybody else they want, including their covered entity. So the cool thing is that without any BAAs in place, you break the HIPAA chain of trust and send that data to whoever they want. So to your point, and I agree with you, I don't have time to do it either. I want to delegate it to somebody that could do something with it. They can tell me what it's about.
I need a custodian.
I need a custodian, I need a caregiver, I need somebody else to make that sense. So it's really helpful.
Excellent.
So I think one of the sort of the big problems we're dealing with is similar to the last two, where we're talking, one of the roles we have, in addition to sort of being the chief complaint box for health IT within the state, is, and a bunch of other complaint boxes, but is to really try to explain what is required, and what isn't required, more importantly, when it comes to exchange, when it comes to policy. So, we're dealing with, I think we have 2 or 3 laws on, mental health, HIV, rules that will require an affirmative consent. We have 42 CFR Part 2 when it comes to the federal substance use disorder data. But one of the biggest interests that we have as a department, and with our Medicaid program, and also within primary care, because of the sort of the movement, or sort of the primary care physician serving as also behavioral health physician too, is the exchange of that data. And there's a sort of hopefully some of this consumer-mediated exchange will support this, or it sounds like it will support this, and hopefully it comes fast, because I think there's a lot of concern on some of these organizations that I can't share anything, especially when it comes to substance use disorder data and knowing what the problem is that every state has with opioids. So that's one of our biggest things that we have to do, and we have to constantly sort of hit at the fact that, these are the rules. You can share information appropriately, and there are ways to do it. If you give a consent, once the patient gives consent, there is, there's a lot of risk, a lot less risk on the provider, and I think they have to understand that. The other issue that we're dealing with when it comes to supporting the infrastructure to be made available to support measurement is, there's a lot of folks out there with plans and providers, ACOs and other organizations, and there's all this aggregation going on within the market, within the healthcare market, is what's the infrastructure that's available and to really support some of the measurement work. Because there's a lot of people with a little bit of information in each silo. Some might be able to get, some system might be able to get lab information from one of the big 3 labs in our state, but not the other 2. Some of it's standardized, some of it's not standardized. So there's a lot of it's going to be a very long slog, I think, when it comes to data standardization and data quality that we're working on.
Excellent. Okay, well, you guys have been covering some of these other questions in the course of your answer, so I'm going to skip around here a little bit. I want to try something. When you think of your approach, what are the roadblocks, gaps, external dependencies? What's in the way of getting at what you're trying to do? Not just within the system, but external as well, regulation, whatever. Let's go in order.
All right. So one of the things that's a roadblock or a challenge for us in terms of moving forward with that data extraction, that normalization, so that we can do and produce quality measures for that, is a little bit of the policy of how we think measures should be done for that. Going back to the last presentation, thinking about eminence versus evidence-driven for that, and not necessarily having a lot of data inform a lot of the policy for that. So it's very easy to abstractly write a quality measure that requires a data element that has never been recorded in 99.9% of EHRs in existence for that. And as a consequence of that, you find a lot of pushback in the measures for that. And one of the things that we're trying to do is actually publish on this to really be able to give information to the public domain for that about what quality measures are working. They're requesting data that exists today and is readily produced as a byproduct of care, and what quality measures aren't. Because if you look at the 25 ECQMs that NCQA has today, or the 300 that are in macro MIPS for it, I think a substantial number are predicated upon data that aren't necessarily well populated yet.
Yes, agreed.
Sue?
So I think that some of our roadblocks come from a little bit different perspective, but they're so similar to what you just said. And so I'm going to talk about 2 of them. One is having healthcare organizations understand the need for and appreciate the value of having somebody that has an academic education in this area. And being able to tie together the use of health informatics and quality improvement together as almost kind of an they get an exponential kind of return on their investment when those 2 things are done together. By themselves, they're both great, but when we can educate students and then put them into the marketplace or put them into healthcare organizations, they stand to bring more to your organization in terms of throughput. for workload. The other thing is something that I think you mentioned, but I'm not sure, and that's the value of having an academic organization involved in what you're doing in terms of research. And
Absolutely.
yeah, and so I thought that based off what you and I had talked about earlier, I was thinking that's where you were going. And so it's been our experience that when organizations report on themselves, that's good. But when you get an academic to report on what you've done, it actually carries a different kind of weight, especially in the peer-reviewed journals, especially in peer-reviewed conferences and things like that. And so from an academic perspective, those are pretty big barriers because we tend to, not we in academia, but we in organizations tend to want to work siloed and very, very focused on what we need to get done, and we need to get it done quickly. And so we forget about, well, how do we tell our story? You know, we've all done something great in our healthcare organizations, but how do we get that story out there so that we can share it so others can take advantage of what we've done and our lessons learned? And so I would say those are barriers.
Excellent, spectacular. Thank you. Ryan.
One clarification, it may not seem that way, but I am very supportive of all the work we are very supportive of all the work that's been done so far to get us to where we are today, and that obviously all the money and time that's been spent. So whether it's HIEs or whether it's FHIR APIs or whether it's direct trust or the work that Carry Quality and Commonwealth's doing and Chic is doing and all the stuff that's happening, we're an all of the above alliance. We're very supportive of all of that work. I think what we're saying is there another way, faster, better, cheaper? Is there another way that we could do this? So I want to make sure that that's kind of clear. So to answer your question about kind of remaining barriers that we have, I think it's a lot. I think it's educating, again, providers that consumers can play a role in their care planning process. And again, I go back to Sheet's conversation over lunch, which I thought was really valuable, rethinking the way that we do everything, not just quality, but everything in healthcare. I mean, this causes a whole rethinking of where we are. So for those who aren't kind of paying attention, every major payer in the country has said that they're now a consumer health company. I didn't know if you knew that or not. Dead true. United Health Group's chief strategy officer, I was in the room when he says we're a consumer health company. Cigna has got a 24/7 concierge line for consumers to be able to play that role. And I could go down the list. Aetna is absolutely, as part of the Caring Alliance, and I can tell you they're absolutely focused on the end user. They're now looking past the employer groups to the consumer themselves. Some of the most well-funded startups in the country as it relates to venture capital money are startups that are actually going to the consumer. That's the other thing, and there are billions of dollars flowing in there. In fact, as we speak to our venture capital friends, they tell us, look, you give us a good idea, we'll give you money. Money's not the problem. They've got plenty of money for you to start something up. Their problem is access to the data, and all of these organizations' problem is access to the data. So again, HIEs have gone a long ways in doing that, but there's still these agreements that need to take place. We're saying to ourselves, look, if APIs are going to get installed, that's phenomenal. Now let's figure out if there's an app ecosystem that can help support that, and that through the combination of HIEs and APIs and these third-party apps, how do we then make sense of the information and make it valuable for the consumer and for the provider long-term to make that work? And we're grateful that we've had so much support in kind of moving in that direction.
Great. So I think since this is a conference about measurement, I'll focus on the problems with measurement that we run into. And one of the things that I have always struggled with is how you calculate quality and attribute it to somebody on 10 different processors in 10 different places. I mean, at some point, the data's all got to come together and be calculated, right? It's got to come to rest in one place. And so almost every approach to pulling the data together, no matter what it is going to have to build a comprehensive record at some atomic level, and I think the atom is the patient that has to be there. And whatever means gets that data together, gets it there. But that's just the beginning of quality measurement, right? That's just having the data set. Well, then we've got to start to add some rigor that I don't think I've ever seen in the healthcare quality measurement space. Where's the confidence interval? Where's that little red asterisk next to my own blood pressure score performance that says this is a statistically significant event and is different from all the others that have gone on before, right? So that I don't get judged based on the 4 patients I happen to have that are in that particular payer group, because the confidence interval would be so wide as to be off the charts, right? So how do so we aren't using some of those basic mechanisms of statistics to decide whether the results we're getting are results we should be basing decisions on and basing payment on. And I think that's a lot of the pushback that comes from the provider community, is that we're going to throw up some numbers under MIPS, for example, on a public website without any confidence intervals on it, without any statistical significance. And that will ultimately undermine our position as measurement people, because it looks like we don't really understand the process. The second thing I think that has been really critical for what we're doing in Oklahoma is to recognize that everybody at the table has a stake in the results of the measurement, and therefore is not an unbiased participant. And so if they are told to gather data from their own system and type it in, it may not be the clinician that types it in wrong, but it may be the business office manager who types it in wrong, or who just drops some people from the denominator. I'm not accusing anybody of it, but we could never detect it if it happened. Right? And so that undermines the payer side of the world's confidence in what they're getting. And it only has to happen once for the payers to walk away and say, nope, you're just going to have to send us all the data. We only trust our own analysis. Right? And that's not a world that's going to be productive either. So what the sort of rubric we've come to is that we think of the between space that MyHealth occupies as being a trusted third party. We don't have a dog in the hunt. Everybody's a member. Everybody's on the board and gets to tell us how to function and where to function, what measures to focus on. And when we calculate the measures, if we say to the providers, you're really bad on smoking, but it's mainly because you don't send us any smoking data. Those CCDs don't have it coded right. So we'd like you to focus some effort on that. And if they can't, then we turn to the payer side and say, 7 of these measures are pretty good. You're not going to want to use anybody smoking. And they will trust us to pull that off. But if the clinic had called up and said, we need you to drop our smoking measure because the data's bad, the payer would never do that. So I think the notion of having a trusted third party for measurement is really important. It's why we look up things on Edmunds.com or J.D. Power and Associates or Consumer Reports before we buy it, is because that's thought of as a trusted, non-biased third party. And I think we have to have that for the measurement world to work.
Thank you, David.
Yeah, I think some of the one of the barriers I think that we are dealing with is we're also paying for some of the health information exchange infrastructure. So is sort of planning for sort of the next step, because the health information exchanges were initially granted, and we did some of our own funding from the state, I think in 2006 through around 2008, and then starting with O&C grants, and then high tech, and high tech's going to run out, and then what is the next step? What does this world look like? Because there will need to be some common infrastructure. Even if all the EHR vendors are totally interoperable and everything works beautifully, we're still going to need to know where people are, and we're still going to need to bring in more and different types of data. And other organizations, community-based organizations, especially as it relates to our Medicaid program, social service organizations and others are going to have to get involved in some part of exchanging information, and sort of as a user and as a contributor of information. I think that's one of the things that I wouldn't describe as a barrier, but it's sort of a thing we're trying to plan for over the next few years. And how do you appropriately exchange information with a social service organization that only needs a little bit of information on nutrition or something else?
Excellent. Okay, again, you guys are anticipating the questions and your answers. But we're getting close on time anyway. I really want to jump to the last one to make sure we get it covered. This was Sue's question that I tried to understand, and let's see if I got it right. What could we all do to make it easier to provide higher quality and more actionable data to the quality improvement process? Does everyone have a role there? What should we all be doing to make it better?
The one thing I would say towards an attitude that we need to approach towards quality measurement in this process for it is don't let perfection be the enemy of the good. Which is, there is a tremendous amount that is doable today. The future is here. It's not evenly distributed for that. The things that David's doing out in Oklahoma for it, we're working with several HIEs nationally. It's not perfect yet. All these measures are not working, and all the things are not filled out for it. But let's work with what we have today for it. And we don't actually have a lot of fire today for it, but we're making do with the things that we have, and we're making progress, and we're making strides, and we're learning a lot along the way that will inform the future process for it. I think that there's always a danger that you throw up your hands and say, well, you're not doing it quite right, so let's just back up and stop doing it altogether for it. Let's keep moving forward and then build upon that momentum for it, and we will fix it. We will change. I don't think that macro-MIP says it's going to be formulated and starting next year is the end state of all this, and I think that the comments from SEMA earlier this week are going to inform a lot of where it evolves in the future.
Excellent. Thank you. Sue?
So I don't see this as a singularly focused, what can any one of us up here do, what can any one of you do individually, but I look at it more as we collectively need to think about this as a shift in culture, and then think about what will it take to enact that culture shift, to think differently, which is what you had talked about, I think the first or second question. We need to get people to think differently. Well, so then I try and unpack that, and I back up from there, and I think about organizations that have gone through culture shifts, and behind every solid and sustained culture shift is a really strong leader. So not necessarily a well-liked leader, but a very strong leader. And I'm just going to give you an example. About a few months ago, I don't know, 2 or 3 months ago, I took a field trip to Miami Children's Hospital, which the CEO happens to be one of our alums. And he was, anybody here from Miami Children's? No? Okay. And if you ever have a chance to go there, you should. Hopefully not with a sick child, but you should. And when I looked at, so he gave me a field trip of their, how informatics and quality are seamless. And so about, I don't know, 15 minutes into the tour, I said to him, I said, you had to get people to think differently in order to pull this off. What they're doing there is absolutely magnificent, and I can't even do it any justice in a couple of minutes. And he said, yeah, that he really angered a lot of people along the way, including some board members, because changing the way people think and enacting a culture shift can be a very uncomfortable thing to do. Nobody likes change, right? None of us like change. We like to be in our nice little comfortable zone, and we'll push the envelope a little bit, but don't change us too much, because then we get really uncomfortable. And what he did was he pushed people way out of their comfort zone into an area of thinking that they didn't even know existed. And I think that that's what needs to happen. And I think that's what in order for quality to not be an afterthought, but to be a forethought, or to just happen, like we don't even think of it, it just happens. Kind of like when you close your door and you can't remember whether you locked it or not. Of course you locked it, but you do it so much all the time that it's just part of your regular routine. That's what quality should become in the healthcare world and in the consumer world. And in order to do that, I think it's really going to take a shift in culture.
Excellent. Thank you, sir.
I definitely agree. I think we've viewed quality as a top-down rather than a bottom-up
Exactly.
Exercise in healthcare. And I've been in it for a long time as well, and I still don't know what quality is. We've got a bunch of measures. I don't know what half of them mean. I mean, I'm being honest, right? And I think one of the problems we've had, and from a Care and Alliance perspective, and just personally, we've rarely asked consumers what they think is quality. Because most of the time, the answer you're going to get back is, can I have access to my doctor 24/7, right? Does he answer my emails, right? Is he giving me the right answer? Is he looking at my whole care rather than just my acute care sickness? Those are things we don't track today on a widespread basis. So the idea of thinking differently is good. We're moving from a centralized institutional environment to a decentralized consumer-specific environment, and that changes everything. I keep wondering why we build bigger hospitals, right? I keep wondering, why is that? Why are we keep building these bigger hospitals or more hospitals when we're moving to patient-centered data homes and we're patient-centered medical homes, and we're moving to the idea of distributed data? And you know, when you look at Topol stuff, you know, it scares you to death. But the idea that, oh my gosh, look at this, that you can actually do pulsometers right on your fingertips and telemedicine, and you know, there's this concept of decentralization that's happening while healthcare is still trying to figure it out. And when you talk to hospital executives, bless their heart, because they're in a really difficult place, because they're still getting paid for fee-for-service in many sense of the word, and they're trying to move to value-based care. I don't think it's that they don't want to go there. It's that they just can't figure out a way to make that transition, and that becomes very difficult. So from the measures perspective, it's involving the consumer in the decision-making process around really defining what quality is. I think that'll really be helpful.
Yes. David?
Yeah, I think that's a really great comment. And I think, you know, the Seamus comments about measuring what matters. What matters to everybody is what gets them paid and keeps their doors open and gets their kid home healthy. I mean, depends on the perspective you've got. And so what matters doesn't necessarily, it's in the eye of the beholder. And figuring that out is going to be really, really important. But then once we figure that out, we have to align the incentives to get that. And I couldn't agree more that, you know, at-risk systems are working more in the direction that patients would like generally than non-at-risk systems. And I think that we need to be looking towards that world. But I hear every day from health system executives who say, yeah, but I've got a foot in each boat. I've got a foot on one curve where my primary care practices are now in this Comprehensive Primary Care Initiative. We love it. They're saying they like their jobs more. They're focusing on the right patients every day. We got a foot in this other boat that says, well, you can't afford not to admit these people because just to get half the savings back. You get the full payment because your bricks and mortar cost every day, all day, regardless of whether you get a shared savings payment or not. So we're going to have to, you know, we're going to have to fish or cut bait on this in a major way.
And I think from our perspective, it's, you know, we require a lot of measures. So I mean, how does an organization go improve on 42 different things? I think which is kind of, I think, impossible. So I think more and more alignment on measurement, I think, is going to be required for us, because, you know, if we think about our big problems within the state, in diabetes, like everybody else's, diabetes, hypertension, I mean, that's what we're trying to focus on for our perspective, and really try to align people with that, because it's just such a big cost of healthcare in the state, and, you know, to keep people healthy, obviously.
Excellent. Thank you all very much. We're right at time. I don't know if we have time for questions or not. Okay. Okay. Well, thank you all very much. I think it was a great panel discussion. I really appreciate it. Thank you.